So early pregnancy stations like ectopic, molar, all of these are, of course, you need to be very, very fluent with these stations. Yeah, we'll do one of these today. And as we did before, one person will do the station, then same station will be done by one or two more candidates. Okay, so then we'll talk about as we go. Shilpa, do you want to, Shilpa, Falak, and all of you, who else did say that they wanted to do? Salma said she wants to do, and I said,
I can also do, ma'am.
Shilpa, you like to do? Okay.
Yes, I like to do. Yeah.
Okay. And did Falak, are you quiet today? Yeah.
I would like to do, but because I took it last time, so I thought let others take. If you can give me a chance, that would be great.
Sacrificing mode. Falak is in sacrificing mode. Okay. We'll start with Ankita. Okay. Timer. I'll give you 2 minutes for reading. Okay. Are you ready, Ankita?
Yes, ma'am.
Okay, so I'll share the screen and I'll give you 2 minutes to read. And then I'll give you 10 minutes to perform. I'm just trying to see if the station can be. Okay, let me know if you can read all of this. Otherwise, not at the moment. I'm sharing soon, okay? So, okay, so share the screens with you guys. Okay. Girls, try to say whatever you want to say because I'm not. Okay, Adila, no worries. I will not be able to keep an eye on the messages. I'm not very good with the messages, okay? Just say. So close this part. Close this part. And make it big and share screen. Where's my timer? I just had my timer here. And this is your station. Let me know if you can see. And I'll do the.
Yes, I can see, ma'am. Oh no, there's something came. Timer.
Yeah, I'm trying to set it for you. Wait. You are fast. You can see the timer and you can you read the station? Or
yes, ma'am.
Is it too small or can you read?
No, I can read, ma'am.
Can you guys, Falak and Shilpa and Salma, you guys, Tony, all of you, can you please try to note down your feedback as we go, okay? Write it down like you get feedbacks from others because what I feedback to you guys will be on bigger points, okay? Like modes of your attack to the station rather than a nitty-gritty of, but I want you to note down the nitty-gritty as well and share it, okay? So all of you will share. Maybe you can share then in the chat screen or some image or whatever, okay? Or you read it aloud as well then, okay?
Hello, I'm Ankita, one of the doctors at the clinic today. May I confirm your name and age, please?
Hi, doctor. I'm Sarah Taylor and I'm 23.
Okay, Sarah, are you comfortable to talk to me or do you feel pain in your tummy?
Doctor, my GP gave me some medicine, so I took it. So I'm okay to talk.
Okay, Sarah. So I gathered from your notes that you are pregnant and you have pain in your tummy and you underwent your scan and you are here to discuss your results with us.
Yes, doctor. I didn't know that I was pregnant, but GP did the test this morning. So I just found out today that I'm pregnant. Yeah.
Okay, Sarah. So when was your last period?
It was about a little more than 6 weeks ago. I think 7 weeks. Yes. Yeah, I'm a bit. Yeah, I'm not remembering very well, but something like that.
Okay, no worries, Sarah. We will figure it out. So Sarah, as we are meeting for the first time, can I ask you a few quick questions to know more about you? Then we will discuss your scan results and make a plan that will be safe and suitable for you.
Yeah, that's fine. Yeah, sure, doctor. Do you know
Okay, so
my
can you-
scan result?
Yeah, I have gone through your results and I'll be discussing it soon. Okay?
Okay. Okay.
Okay, so can you tell me more about your pain, Sarah?
I started having some pain in my lower tummy. That was 2-3 days ago, actually, but it was bearable. I just thought that, you know, maybe I didn't know why it happened. I thought maybe after exercise, I pulled my muscle or something, but then it started increasing. Yesterday, it was quite a lot. So this morning as well. So this morning it was unbearable. So I went to the GP. He gave me medicine, and then it seems like it's okay for now. I just took medicine an hour, 2 hours ago.
I'm so sorry for your pain. Do you have shoulder pain also?
No, doctor.
Okay. Any fainting attack?
No, doctor. I didn't have. I had that 2 years ago when I had my ectopic pregnancy. I had fainting then, not this time. I'm not sure if this is the same thing going on. I was worried about that.
I'm so sorry about your previous pregnancies. But can you tell me in detail about your previous pregnancy, Sarah? I know recollecting past events might be difficult for you, but it's important.
You know, doctor, it's fine. I only had one pregnancy, and that was in my tube. They removed my tube. So that's it, really. We started thinking of getting a baby now. So I stopped my contraception some time ago. So that's it, really. I don't
So
have
you
any
are
other.
planning this. So this pregnancy was planned one. You are trying for the pregnancy, right?
Yes.
Okay. So how was your recovery in the previous pregnancy, and how was the surgery done?
They did via the camera,
Okay.
the laparoscope, and the recovery was good. It was quite fast.
Okay. So do you have any problem with your water work or bowel movement at present, Sarah?
No, doctor.
Okay, that's great. So do you have any medical problems for which you might be visiting your GP?
No.
Any history apart from that ectopic pregnancies? Any history of surgery apart from that surgery of ectopic pregnancy?
No, doctor.
No.
Never.
Oh, okay. So how are your periods? Do you feel pain during your periods?
No, periods are fine. Just mild, sometimes mild pain. That's it.
Okay. Pardon me to ask few personal questions regarding your sexual life. Do you ever had any sexually shared infections?
I think I was treated a few years ago.
Okay.
Yeah.
So, okay, I'll document it. Do you have any family history of concern, clots, anything?
No, doctor. No.
Oh, okay. So, just few checklist question. Do you have any allergy?
I don't have any allergies.
Okay. Are you aware of your height weight ratio?
I think it's 23.
Okay. And blood group?
I don't know.
Okay. We will check it. We will perform the test. And any reservations for blood?
You mean transfusion?
Yeah.
No.
Okay. So, do you smoke or drink alcohol? Pardon me to ask, any recreational drugs?
I do smoke sometimes. Yeah, 1 or 2 a day.
Okay, I respect that. But have you ever thought of quitting smoking, as smoking might be injurious to your health?
I tried, but it's only 1 or 2 that I smoke. So.
Okay, Shara. But if you allow us, we can attach you to a stop smoking center also, so that they can help you with this. Okay.
Okay. Do you think 1 or 2 is a problem?
No, yeah, you can do 1 or 2, but it's better to, or it's always better to avoid smoking. Okay.
Okay. Okay. Sure. Yeah, you can
Okay.
report.
Thank you for the history. Anything you would like to add, Sarah?
No, doctor.
Okay. So, Sarah, I can see that you are here alone. Do you need to be someone with you, Sarah?
I'm okay, doctor. Is it again ectopic?
I'm afraid, yes. This time also it's an ectopic pregnancy, Sarah.
Okay.
So, do you want me to proceed, Sarah?
Yes,
I'm
please.
so sorry.
It's all right.
So,
Yes.
I think you might be aware of the management options like medical management and, you know, medicines and surgery. You might be knowing all the options, you know.
I do, yes, yeah.
So yeah, here again, the wait and watch and the treatment with the injections will not be possible for you, as I can see in the scan. The fetal heart is there in your left tube. The pregnancy is in the left tube, and we have a fetal heart rate is there, and there's a high chance that the medicine might fail.
Okay.
So we are left only with a surgical option. Okay.
Okay.
Should I proceed?
Yeah, okay.
Okay, so yeah, again the surgery will be done, and that can again be done with a keyhole surgery that you underwent the last time. But sometimes it won't be possible to be done with the keyhole surgery, as there is a chance that there might be adhesions inside your tummy, or sometimes due to technical difficulties, like there might be a lot of blood inside, so will not be possible. Then we have to make it a cut tummy operation.
What are adhesions?
Sorry.
What are adhesions?
Okay, sorry. There might be certain everything might got stuck inside your tummy. We will not get a space to enter sometime due to previous surgery.
Oh, okay. Oh,
Everything might got stuck together. The bowel and the womb.
okay.
Yeah.
Okay. So I'll have a big scar then? Big cut?
Yeah, we will. The MDT team of group of doctors, senior gynecologist, anesthetist, and senior nurse will be deciding. We will try for a keyhole surgery, but if it's not possible, then only we will think of cut tummy operation.
Okay.
Okay. So now coming to the operation procedure, there's there's a chance that you don't have another tube, so we can remove the products of the conception from the remove the fetus baby from the tube, and then we can leave the tube over there. Okay.
Okay.
But there's a high chance that but for that you may require a regular follow-up, and there's a chance that you require again 1 in 7 women you will usually require a second surgery during their follow-up, and in the future there is a risk that you again might have an ectopic pregnancy in that tube in case if we leave the tube inside.
Okay.
Okay. So in case, yeah, but sometime it won't be possible for us to leave the tube in case if there is heavy bleeding during removal of the tube, or the tube is completely damaged, then we have to do a complete surgery.
Oh, okay, doctor. So what happens for future children then?
Okay, so there will be an option of, thank you for your time.
Okay, good. Okay, so
actually, ma'am, I was not able to see the timer. That's why I was not able to manage the things. I thought I have 2 minutes left.
It was
according to
yeah, okay. Timer, I think it was 2 minutes left when I moved away from the screen. So 2 minutes were left at that point, when I stopped sharing the screen. I forgot about the timer. I thought it's the question in front of you. And I thought you should be able to see my expressions better. So that's why I stopped the sharing. Sorry about the timer, yeah. But if you were looking at the timer, you would probably have known that I shifted away from the timer when it was already 2 minutes left. Like it wasn't like you couldn't think of 2 minutes now.
I
But
was
what
looking at
happened-
my timer, ma'am, and according to that, 2 minutes was left. That's why I was going slow. Maybe I mismanaged it.
Oh, your timer, yeah. My timer was absolutely bang on. Actually, I started few seconds late, so you got like 20 seconds extra already, okay? So what did you think, what else you could have done, or what did you think went well?
I was not able to complete the station, yeah.
Okay, and why did you think you were not able to complete anything you can particularly focus?
But I was crisp at the history also, ma'am. I didn't ask any waste questions. I took all the relevant questions only.
Relevant is good. Look, relevant history is good, but did you see the time for your history?
Yeah, I was not able to time management. No.
Okay, how long did you take history for?
I don't know, maybe 6.5 minutes according to because I couldn't get the time in the management part.
We are not very rich with time, okay? 6.5
Yeah.
minutes is a lot. Okay. What would you have asked, and how would you have made it better?
Just by cutting down the history part.
Okay. Girls, what's your feedback? Okay, Falak, you start.
Actually, Ankita was very clear about her content. She knew the content. But there was a bit of lack of empathy. Maybe her voice was maybe she was a bit rushy. If she would have started, because she knew this is another ectopic and it is a breaking the bed news, and breaking the bed news will take some time. So maybe she could have omitted the family history and a little bit about smoking alcohol, because I think the main agenda for this station is breaking the bad news, telling her the further management plan. So I know those things are important in history, but when we are having an idea that it's almost 6 minutes and we have to break the bad news, that is the most important thing about it. Either the other way was breaking the bad news first and then taking a short history, only including the previous surgery, the recovery, her blood transfusion, her blood group support is very important, and then just move on to the surgical management.
Yeah, I can tell you that there are more things as well. So if you are going into the station, you go with open mind. This is not all, okay? Shilpa, you have a feedback, please? On the approach as well as on content, okay?
I must appreciate she did really well. Her voice was very, very nice and things were nice. Only thing, that part is true that smoking at the moment, if they're saying 1 and 2, we can skip that part and discuss the better things. Because ultimately leading into that confusion, is it bad, is it good? So we can just forget about talking about it. It wasn't really important that time, right? We can just say, okay, and then carry on. Asking the history was important, and probably telling her that smoking can one of the risk factors for getting an ectopic. So asking was important. When she told about 1 or 2, then we can just go with the flow and finish our topic. And if we have time left, probably we can connect her to the smoking center if the time permits in the end of the discussion, rather than putting it first of the discussion.
Okay. Yeah, that I will take care.
Yeah. Otherwise,
don't decide just yet. Don't decide just yet. Let's go on. Let's go on and get Ankita, don't jump to what you are going to decide. Okay. Okay. Anything else?
About breaking the bad news, we could have concentrated more on the what is her perception, how she's going to take it. We're giving her a little more time to absorb the news. Correct, like 10 minutes, 20 minutes. I know time is a very big constraint, but the role pair is going to give us marks supposedly. So if she's not convinced with us, then we are not going to score anyways. So looking at the face, we know that she's not happy. And then if she's not happy, the main thing is just to make her more comfortable and talk about, I understand, and this happened, and I'm very sorry. What we can connect to the fertility people. Whenever we have to break a news, probably giving her a little crisp thing that what we can do immediately, rather than going to the surgeries and talking about it, that we have all the options available. We can if it is happening this way, we do this way, or we can connect you to the fertility people. You are going to have a baby. We can just wait and watch. Do not lose hope. Probably these lines would have come early because she was just feeling so sad already, correct? Telling her she wants to have a baby, and then we are breaking the news that it's not going to happen to you. So probably just counseling her in a better way first.
Okay. Yeah.
1 or 2 months, and then we proceed with
Good.
the whole
Good.
discussion.
Yeah. Okay. So what I'll do, one way is to let many of you, you've raised very good points. Okay. You too, Fala. Absolutely. Very good points. And Shilpa, you too. Very good points. I'll take some points from others as well. But what I'm saying is that as we proceed, one way is that I keep enjoying what you guys are doing, and then in the end I break the bad news on you as well, that these are the things that you missed. Okay. But other ways which I find a bit more helpful is that I give you at least some main bulk of if I see an elephant in the room, I indicate that to you so that you can try differently. If you planned in style A, then you can plan in style B in the next one. Okay. So Lata, would you think that she could have probably broken the news first, or would you think she did fine with her approach? What was your thought on that?
I think at first I'll take history. It is good.
You will take history first, okay?
Yeah, yeah. Then breaking the bad news. But here, what I observed, you told Ankita, the doctors, I have ectopic pregnancy. You already, before her, you informed her. So it is how you handle this situation. Basically, patient told you before I break the bad news. Yeah, before I breaking the bad news, you told me, doctor, I have ectopic. So,
do I have ectopic? I asked, do I have ectopic? Okay. Girls, I think the idea of breaking bad news before or after is always, something that people will have difference of opinion on that. But as you said, have you joined now?
I can hear.
Yeah, okay, sorry. So yeah, I think Shilpa got logged out somehow as well. Okay. So I remember these 6 minutes. Why were these over 6 minutes spent? 6.5 minutes were spent in the history. Okay. You guys do that. I know you guys have got it's the BBN is a big thing. Okay. BBN is something that makes people nervous that, okay, it's something that kind of, what will happen? What will be the patient's response kind of feeling that, then you try to postpone that BBN. You think that let me get my jobs sorted first and then I'll tell her. And she will not waste your time, okay, if you do the BBN. But what happens with the BBN, that she had questions, yeah? You didn't have any time for my questions, really. I wanted to ask you about my fertility options. You never had any time because what happened was that 6.5 minutes were used in history taking. See, Ankita? Yeah, 6.5 minutes were used in history taking, and the rest of the time you spent in, kind of telling me the management part. Despite that, I saved you from that because, I said I had an ectopic pregnancy. I said I had, that laparoscopy. So I saved you lots of time there, and I put a 3.6 centimeter in there with history of pain and all that. So you don't have to focus too much on that and saving your time. So the station was designed to save your time, really. Okay. But what you did was you did say that, okay, you know that already. That's not a very good sentence, actually, that you know that already. You can phrase, I know what you meant, okay? You can phrase it slightly better. So I can explain all the options to you again. You have to reassure her that I am in no rush. I can explain to you. Do you want me to talk to you about the, various options? And then I could say, yeah, I think I know the options. So, and you could have carried on from there, okay? So there's always, you don't shut any doors there, okay? You should try that you don't shut any doors there. Because now I will be wanting.
I don't know. I just, can you hear me, Dr. Sam?
Yeah, I can hear you now. I can hear you now. Yeah, I can't see you, but I can hear you. Okay.
No, you can't. Yes, you can.
I can see you now. Yeah. Okay. So what I'm trying to say, you girls, is there are a few things. One thing that you did a bit of a mistake, I would say, Shilpa, in your assessment as well. And sorry, I'm kind of trying to mix everything and trying to bring out the big things first. So you said that you will probably leave out the smoking part because it's a big station and she has to address things. So I'll want you to remember that smoking is one of, she has come with a second ectopic, isn't it? So what are the risk factors? Isn't smoking a big risk factor and STIs? So I'd rather say that don't forget smoking at all. Highlight to her that this is one of the important risk factors. When I'm saying, is it just one or two? Is it a problem? Then don't feel nervous about that, Ankita. Don't feel nervous that, yes, even one or two cigarettes a day can cause cardiac problems. Okay, they are big issue. Never say any number of cigarettes is okay. Never say no, it's not a risk. Okay, but you, if we go back on our audio, on our video, you would see yourself, you know, saying that when I said, is it a risk? And you say, no, it's okay. And you know that you don't say that. That's a very dangerous thing to say. So please feel. Okay, so Ankita was out and I was talking to Ankita. Okay, so girls, is it my connection or your connection that's causing you to disconnect? Can't be my connection that's causing you to disconnect, must be yours. Mine is not very good connection, this connection today. Okay, so just a warning. If I get logged out, I'll log back in, so don't worry. Okay, I've been given warning on my phone that my connection is a bit unstable. Okay, so yes, smoking, we're not going to ignore smoking. Ankita, please say that you are here because it was your station. I want to give you the feedback.
Yes, ma'am, I'm here. Yes, ma'am.
Okay. Okay, so smoking is very important. Even one or two cigarettes are very important. Feel very strong on your feet when you're talking about smoking. Feel very strong. Feel that, you know, yes, smoking is a problem. Even 1 to 2 cigarettes is a problem. Don't say, I respect that. Why do you respect that? You don't have to say these kind of sentences, okay? You show respect is a different thing. Saying that I respect that is not, you know, I don't know what kind of sentence it is really. So she says, I smoke, you say, okay. So you are respecting, you're not judging. You're saying, okay, are you aware of the risks though? You know, politely, sensitively, gently, and with respect, you're asking, you're not judging and all that. Saying I respect that is very strange here, okay? So smoking was important. Then other thing was that, yes, you said, was it you, Shilpa, you said that there were 2 things, 2 agendas. I think even Palak said BBN and management plan was the main agenda of the station. So let me remind you that because this is a recurrent ectopic, addressing her risk factors, exploring and addressing why is it happening to her again and again. That's very important. You can't really miss that part, okay? So my way to go in, when she especially asks you, just then don't, that's a bit of a put off for a patient, for a role player, if she's asking you. So in the station, if she's patiently waiting and for you to tell, that's fine. You can wait for the, you know, for the history and then tell her what's going on. But if she specifically mentions that, what's my report, and then you don't say, okay, I'll come to that. Okay, I keep giving you guys lots of tips around this thing, that when role player utters a word, one word, that's called a cue. Okay, she's not just blabbing, she's giving you cues. She says, what's my result? That's a cue. Your success depends on how good you are in grasping that cue, or you can say that, oh, get lost and you move on your path. Okay, but your path isn't your path. Okay, it's not where she's got your numbers. Have you ever seen the treasure hunt? Yeah, you played treasure hunt when you were children. Yeah, you used, where could be the treasure? There would be some signs and some, you know, where you'd find. So role players' cues are the signs towards your treasure. Treasure is your marks. Okay, do you guys get that? Yeah, do you guys get that? That if she is saying, tell me the result, or she's asking you the result, then would you just go on taking the history and tell her that I'll come back to you later? Girls, any response? Palak, Shilpa, Lata, anyone?
Doctor, I feel that he should respond to the role player at that time only. We should kill that sentence of the role player that time. We should not wait or linger on the question next time that, okay, I will come back, because we will not be able to answer the question at the end, and the time will be finished and we'll be losing the marks.
Absolutely, absolutely. So here the trick here is that I have got few questions here which you never even reached. Okay, I asked when there were like 2 seconds left. I said, what are my fertility options? Because you never let me use, you had your agenda in head that I'll take a history. That was your agenda. Okay, so you thought that I'll take a history and I'll address that and I'll address that. But if you break the news first, then I'll quickly come to my questions, isn't it? You break the news and you say that, oh, I say that, I'm sorry, this is like, this is the result. And so are you okay for me to continue, isn't it? And then she can say, okay, yeah, sure. So it's better that you ask her, do you want me to discuss the management options? She could say, oh, I know the management options. Can you tell me what will happen in terms of, or she could say, yes, please, but I also want to know what will happen. And I said that I'm planning pregnancy. This is a planned pregnancy. You still didn't come to fertility options, yeah? You think it's a big mess or not?
Yes, ma'am. Addressing her concern was the main thing, and the fertility here was the main thing, actually.
So do you guys feel scared of breaking the news first? Could you think it could save your time if you broke the news first? Come on, girls.
Ma'am, I think we will be talking about the management plan, and the history will get lost. We will not be able to attend the history again. So that's the scare. If we start talking to the player first,
I know.
Management, and then it becomes like that we are done with the information gathering is gone then. So if we attend the role player, it should be if it is that we go organized, we are unlikely to do mistakes, right? If she was say some lady who had asking about the occupation, if she was a sex worker, that she was at risk of having multiple infections and PIDs, and then she got ectopic. So if we go in a pattern, we are less likely to forget something. And
if you think, Shilpa, if you think that this is totally going to ruin your station, I wouldn't want you to change your strategy then, okay? But there is always a strategy which, and I remember you said that you see lots of patients internationally as well, yeah? So you probably don't have that kind of time to, I don't know how much digging can you do in a medical student format, but if there is an important news in front of me, I'll tell you something, and you can, if you think that you can make use of this, fine. If you think that you should you should still use the same pattern that you are using up until now, then what I'll say is that you then have to do a better
time management.
Time management, yeah, absolutely. The time is so important. You can't really mess with that. So if I was doing this, and you said information gathering would be missed. So information gathering doesn't mean that you take all the history, okay? Even if it says in the station, do information gathering, it only means that the relevant information. So if you keep, going around with kind of say, questions like, it's okay to miss even what, if you're not prescribing, you can even miss allergies. What the time you're prescribing, you can ask allergies. So what I do is I ask the patient, first of all, well, I see if there is a BBN required, I do the BBN. After the BBN, I take a permission to proceed, okay, give her a pause, because you have to remember, you are worried that I will not be able to finish the station. They want to see whether you paused after the BBN, okay? So it can either be your agenda or their agenda. Their agenda has marks. Your agenda has your personal satisfaction that I completed my, but they don't have marks for your templates, or they don't have marks for your agendas, okay? They've got marks for their agendas. So if you did BBN first, you will have an opportunity to pause, empathize, ask her what she wants today. Maybe she doesn't want to discuss the management, she knows it, maybe, because she had an ectopic, she got treated, who knows, you can't judge before that. So then you can, whatever happens next, you can gently ask that, whatever she asks, okay, tell me about management. Even then, before that, you can ask, can I ask you a few questions for that to help you with the management options? And then, you can ask the questions. If she asks, no, tell me about fertility, say again, that can I ask you some questions before? So you have that. And then now you know that you have to ask very, very targeted questions, okay? And that will depend upon what she's asking. So how I was proceeding in these kind of things was that I was doing BBN, asking just one question maybe, or two questions, and asking her what does she want me to address. Proceeding with that, in the mid, if I find that, okay, this requires more information, she gives me a question which requires more information to answer, then I say, okay, so can you tell me this before I respond to this, do you have any history of this or this? Okay. So, I proceed like that. And so I am able to answer all her questions, and whatever information is required for that, I take the information as I go. And I remember, I think I mentioned before as well that Dr. I think Sikandar, his name was, in RCOG course. He's a very senior RCOG faculty member, and he does RCOG courses as well for them. So he was begging that please don't take a detailed history. You guys are so much addicted to detailed history. He was begging. He said relevant history. Even when the station says information gathering, it doesn't mean that you waste time for yourself or this role player. So try to be flexible in your approach. Try to be, if you are adherent to one system, one format, then probably it doesn't give you much room to address patients' questions. Okay, so we'll try this again with another one, and you'll see that after this load of my input, I've not given 100% input at the moment. I might have missed things here, but this approach is the main issue that I'm seeing that consumed 6.5 minutes in Ankita's case, okay? Because she wanted to do the history first, okay? I know it may sound difficult in the beginning. If you think you can do it with your format, try that. Let's see if you can do that, okay? So you can try that, but knowing the station and now you know what I'm going to say and all that should not change, because I'll still see what questions you've asked and what could you have missed if you didn't ask those questions, okay? Yeah, so who wants to go next then?
Can I do it, ma'am?
Try, yeah, please.
Yeah.
Shall I start the timer on and I'll show you the station, and please try. And I'm not saying try the way I'm saying you to try. I'm saying you can try to modify your way, or you can try to make your way more vigilant, but now you know that you have to address various things. You have to address the risks, and you have to address. Do you need 2 minutes then? Okay, no. Girls, another thing is that can you please try to make those bubbles if you can, yeah? And try to share on here. So rest of the girls, not Shilpa, of course, unless Shilpa can make in 2 minutes, try to make different aspects that we said we need to cover these things, okay? So that should help you with your revision. If you know that these are the aspects that I need to, then you don't need nitty-gritty to remind yourself. You just need to know what are the aspects that are important. Okay. Okay, let me start the timer.
Hello. Oh, yeah, you can start. Yeah.
Hi.
Hello.
Hi.
I'm Shilpa, one of the doctors in the emergency today. May I confirm your name and age, please?
Hi, doctor. I'm Sarah Taylor and I'm 23.
How are you, Sarah? How are you doing today?
I'm better, doctor. Thank you.
Sarah, so we have received a letter from your general practitioner, GP, mentioning about few of the concerning things about the pregnancy and the sonography. And I'll be discussing the same. They have mentioned about the pain. They mentioned that you are in pain. Should I arrange a pain relief first to continue, or how are you doing?
It's better now, doctor. I can talk. Yeah.
So Sarah, are you aware what is in the report?
I know that he said that the pregnancy test is positive, but I haven't heard about the scan. They did a scan as well, so I don't know.
Yeah. Yes. Sarah, there are a few things that I would be talking to you. They are a little concerning to discuss. Can I ask you a few questions prior to proceeding, and then we can talk about the report to you and what options do you have? Would it be okay with you?
Yeah, sure. Sure.
Yeah. So, Sarah, this pregnancy, was it a planned pregnancy for you?
Yes, doctor. We wanted to have a baby.
Yeah. And so did you had pain or bleeding? How was it?
I had some pain from 2 days ago. It got a bit bad yesterday, and this morning it was enough for me to go to the GP. And I was worried because previously when I had pain on my right side, they said it was in the tube, and I was worried that it may not be the same.
I'm so sorry to hear that, Sarah. Can you tell me a little bit more about your past pregnancy? That was the pregnancy, but was a problem? Like the tube, one of the tubes had a baby, and we have to do what did happen then after that?
That was again, we were, I didn't plan that pregnancy, but we were very pleased. But then they said that it was in the right tube, and they said that they had to remove the tube. So they did with the, what that's called, camera operation.
Yeah. So that was the pregnancy. Did you had any babies other than this?
No, doctor. No, I just finished my university, and I was then I started planning. Yeah.
Okay, Sarah. So little bit about your personal things I would like to ask you. Did you ever had sexually shared infections earlier?
I had, when I was in my teens, it got treated.
And about smoking, do you smoke?
I do just 1 or 2, doctor, 1 or 2 in a day, not a lot.
What is your perception, Sarah? Do you think it is okay or it is not? What do you think?
Just, doctor, I thought there is just 1 or 2. So, I mean, I don't smoke like my friends. They smoke like 20 in a day. So I mean.
Yes, so that is true. Everybody has their body, and everybody has the body that react in a different manner. So I would still say 1 or 2 cigarette is also not okay. Correct. But of course, we are going to discuss the report, and I want to share that with you. Do you know your blood group?
Blood group? No, doctor.
No. Okay, Sarah. Anyways, we will investigate you to find out. So, Sarah, I have confirmed the report belongs to you with your NHS number and your name. And I'm very sorry to say that this time one of the other tubes have a ectopic pregnancy, and the pregnancy is a live pregnancy. So baby is growing in one of the tubes, and that is why probably the pain is coming. And the size of the baby, if it's a live pregnancy, we are very much worried about you, Sarah.
Live
pregnancy? I'm very sorry, Sarah.
So live pregnancy, doesn't it mean that it can continue?
No. So Sarah, when there is a live pregnancy in the tube, so the tube do not have the muscles around that can allow the pregnancy to grow. It has very high tendency that it can burst, and that would invite an emergency. And with the sonography report like this, we should be actually asking you for an urgent admission and possibly posting you for the surgery as early as possible. Do you want me to talk further? Do you have friends around who can come? How are you?
It's okay, doctor. You can talk to me. That's fine.
So, okay, Sarah. So what should be the plan at the moment? If I have to talk to you, would be that, you had the past ectopic pregnancy, correct? So we happen to do the tube, how the keyhole surgery was done. So in ectopic pregnancy, we have various options. We can give an expected management, we can give a medical management, we can give a surgical management. But if it is a live pregnancy, so waiting for things to happen is not a good option. And medical management is also not a good option for us. And in this situation, admitting you, getting few blood tests done, knowing your blood count, your blood group that we are not aware of, arranging few bloods, I'm going to inform my consultant, my colleague, my OT staff, my sleeping medicine doctor, and I would also like to give you the consent form for this. Do you want to know in detail about the surgery? How do we do? What are the options in the surgery, Sarah?
I had it before, doctor. It's okay. I'm just worried that what will happen to, is it like, would you remove my tube?
So Sarah, I would like to talk to you about it. So when we go, we again do a keyhole surgery. So though it becomes little technically challenging because of the previous surgeries, some of the part of the abdomen gets stuck. So it becomes technically challenging. We would try to save the tube if it is that we can save. And saving a tube would be, we call that surgery as salpingostomy. Like we just take the pregnancy tissue out and then make sure that there is no bleeding. And we come out, of course, the tube is there. So the possibility of conceiving spontaneously after that is there. But there are still chances of having a tubal pregnancy next time as well, because the tube is little damaged. And the chances of resurgeries, like 33 and about 3 in 10 women can require repeat surgeries because the sub-pregnancy tissue can still grow. We sometimes have to give injection methotrexate. It is one of the cytotoxic drug to kill any fast multiplying cells. And if on the surgery we find that the tubes are better removed, we get more benefit out of it, then we sometimes have to take that tough decision of removing the tube. And if both the tubes are removed, Sarah, I'm very sorry, then the pregnancy spontaneous is not a possibility. Then I can talk to you about the fertility options, like what we have after that, we can connect you to the fertility specialist. And then, have you heard of test tube babies? We remove the eggs from the woman, take sperms, and then make the small babies who looks very nice and put it in the tummy at the right point. And that would be the only option available if we have to remove the tube for the future babies.
Okay. But okay. I'm not sure, why is it happening to me?
Sarah, there are a few risk factors as the information what you have told me about. See, past history of sexual transmitted infections. Have you heard of chlamydia and gonorrhea? These are the few bacteria, they get infected, they damage the tube, and sometimes the damage is so permanent that it keeps on happening, Second thing is smoking. As I strongly mentioned, that 1 or 2 smoking is also not okay. It causes inflammation in the body and inflammation in the tube, which just makes the pregnancy stay there.
Okay,
Sarah. So what I feel, I should admit you. I want to offer you admission. I'm going to ask sister to take your blood sample, nurse to take your blood sample. I'm giving you the consent form. You can go through it. I'm arranging the OT and sleep doctor and everybody available. And I'm going to inform my consultant, and please do not eat or drink henceforth. We'll be happy, and I'm going to receive you in the OT then. I would be somewhere around, Sarah. If you have any further questions, please inform nurse. I'll be around. I'll come and talk to you. I'm sorry, Sarah, for this. We have to do it.
Okay, doctor. So
See you around.
I don't know what to do. I don't know what to do, doctor.
You.
Very stressful. Yeah, don't know what to do.
I'm sorry.
Okay. Okay, girls. So
Yeah.
what do you think, Shilpa? How did it go?
I somehow finished the station. Yeah.
Good. I could say good on that. So any thoughts other than finishing the station? What do you think went well and what do you think could be better?
I think I knew what to speak after you have discussed, so it was a little easier for me to talk. I know
that was on purpose because I wanted you to get used to rather than, try keep testing. Because as I said, there are two ways. One way would be that I keep wasting all the time. The other way would be that I give the feedback so that you have the opportunity to try that one straight away. And I feel that it's better because it's not a summative assessment going on here. This is just a formative feedback and all that.
I did that. So I asked the patient and started speaking about the bad news first and take a minimal history and took more time on talking.
Minimal history was very good. Yeah, absolutely. Minimal history was very good. Do you think you missed a lot by,
Not very much, I guess.
Yeah, you could. Absolutely fine. If you,
I did not ask about shoulder tip pain, this pain, that pain. I know it is an ectopic. So
yeah, you know that this is surgical option. This is clear-cut surgical option. So it's okay.
Yeah, well, asking about pain, she says, I'm fine with the pills. I'm doing well. So I could have given her a medical option though, but since the pregnancy was a live pregnancy, I know that we have to operate her. So talking to her about how was the present pregnancy was not really important. If she had a previous baby and then we are trying to give her fertility options, then it was a problem. That if she has a baby, then NHS is not going to sponsor the fertility treatment for her. So I asked about, do you have another baby?
And she didn't have another one, and you
so this pregnancy can be funded by the NHS.
Yeah,
so,
good,
yeah.
Good. Absolutely. Anyone else?
No need to mention about this NHS number name. That was only I was thinking, ma'am. I have verified your name, NHS number with the report.
Did you say that I've checked you?
I did say that. I think
I did. When the report is given there, then it's
the patient safety.
When the report is given there, then you must say that's a patient safety. When the report is not given, but it's mentioned in the GP letter only, then please don't say that, okay? Because GP letter, you don't have a report. So some people, they see the information in the GP letter, they still say that I've confirmed your name. And I've heard people saying that. And then I say that not in that case. When it's mentioned inside the GP letter, then you don't say that I've confirmed your name and address on your report. You started the the consultation by identifying the patient as per mentioned in the GP letter. That was fine. But here there's a separate report you will say, and that's a patient safety issue. Okay.
Yeah, that's what I thought.
Okay. Anything else, girls? Now is that I think if you hear, I'll try to share the your station with you, Shilpa.
Yeah.
And Ankita's station with her. I'll try. I'm not sure when I can find time that requires some work on IT. Okay. But if you hear that your first intro sentence was a bit long, okay, try to talk as if you're talking to a child. Okay. Like one sentence, I mean, okay, because patient is in pain, isn't it? Their understanding and their focus, you have to remember that break down your introduction always. So you said 2-3 things. I wasn't able to write because I was trying to focus. Okay. You said 2-3 things in a row. And then you, next you asked that, can I ask you questions and all that. So that try not to do that. And also when you were trying to, it was very good that you took only relevant history. That was the good point. And you broke the news right in the start, actually, after asking just one question or maybe two questions, you broke the bad news. Now, what I would do would be, I would ask, what is it that you want me to address? Okay, that gives you a better kind of way forward. Patient may say that this is what I want you to address, do you want me to talk about the management, or is there anything else in particular you want me to address first? Okay, you can say that. That would sound very good, and they will mark you better for that. Okay, that you are making the patient a partner in her care, and you are asking what she wants out of this consultation. It's very important. The patient may end up saying that I didn't want any of this. I knew all the management. I'm worried about these things. So it's always good to say that, I can talk to you about the management options. Is there anything in particular that you want me to address other than this or before this? So it will be a good question if you can say that. Okay, then you tried to finish, and then you were in lots of rush because of that. Yeah. I was like, all the times in the last 6 minutes, I was like almost like this, thinking that when you will let me say a word, okay? Because right from when it was still 5 minutes remaining, I wanted to ask, why is it happening to me? Okay, actually it was almost 6 minutes remaining when I was wanting to ask, but you were not stopping anywhere. You continued like non-stop, and that is, you know what, honestly, they will mark you down for communication with patients on that. That's dangerous practice. Your anxiety is very dangerous. Don't feel anxious. I mean, you knew everything. You didn't leave any stone unturned. I admit that, okay? You knew all the aspects that need to be covered, okay? But what I'm saying is that your anxiety, it doesn't help you. Because your anxiety means that you have a focus in your head that I have to complete this. But please, you are in a consultation, you are in a conversation. Consultation is equal to conversation. It's not one way, expression of what the plan of management is. So please always try to calm down, relax. If you're not able to finish, they won't penalize you if you're doing good, okay? I can assure you, they won't penalize if you're not able to finish. If you are going well, that's what matters, that's what counts. You can't rush to the destination. If your journey was bad, they won't mark you just for the destination, honestly. Okay, so you were getting anxious that I have to, and because Ankita wasn't able to reach, those kind of.
Even if you don't complete the station, we won't score.
No,
see, in a normal consultation, there is no time restraint that we just talk.
Who says that? Who says that?
Most of the people know. They say that you have to finish the station. So if I have to finish the first station, then I have to be more focused and me speaking more.
No, me speaking more is a route to failure. Okay, that you should remember, please. Now I say things based on exactly how we do things here. Okay, so if you're thinking that me speaking more is absolutely not. That's your idea. Is here because this is what you're thinking. Some stations, RCOG may sometimes. I think if I become a part of the team, I'm gonna say some stations should be more listening stations. Simply seeing your patients and listening how you are letting the patient, come, get things off her chest if she's worried about things. You need to listen as well. So it's not about you speaking more. It's never about you speaking more. It's never about completing the station. It's good to complete the station. But girls, all of you, please tell me one thing. How do you know what the station is? You don't really know what the station is. There's just a question sitting there and you're thinking that you know all the station, what that is? No. You will find out about the station only when the role player leads you to. Role player is the torch bearer. She is leading you to this direction, this direction, this direction. That is following her lead is completing the station. Okay? it may be very difficult to swallow, because this is not what overseas people teach you, unfortunately. Okay, even everyone will say you, it will be very good to complete the station, but what is the station? You think that question sitting there and you've got a template here in your head is the station? Then you are quite mistaken about that, please. Okay, your station is hiding inside the role player's head. Okay, yeah, you see, so many times you don't know what questions you will ask, do you?
No.
If the role player is saying in the end that she has questions, you failed then. Okay, because if she sees you are asking her what she wants and you are telling her, and she knows that she asked questions, so if she took your time, then it's not your fault, because she was asking those questions. She was taking you to, okay, there are 2 marks sitting here, there's 1 mark sitting there, 2 marks sitting here. So she is doing that treasure hunt help for you by giving you those questions and those cues. So you actually, this is a grave misunderstanding, I'll say. Not only great, it's a grave misunderstanding, but thinking that the question that you see there is your station and along with the template that's here in your head. No, it's the head, but it's the role player's head. It's not your head. Okay, so you have to bring it out from her head by asking, by letting her talk, and by, letting her pose her questions to you. Okay. So if you keep non-stop talking, then it will mean that you are losing that opportunity to respond to the role player. That's where your pass was. Okay, you just gave up on a pass just because you thought. So what would happen here is you won't fail the station. I have to be honest. You'll probably score somewhere in the information gathering, somewhere in the applied knowledge. Okay, maybe you will fail communication with the patient safety. You may fail because you didn't know what her concerns were. She may have, graver concerns, and you may fail on that. Yeah, communication with colleagues, I don't think you lose mark on that. But yeah, there is a greater risk if you follow your template. Okay. And if you want to complete this station, like I can see that you guys have lots of preparation and you know the topic inside out. I just want you to relax, and I want you to relax and believe in yourself that she is a patient who has come to you. She's not going to, there's no problem here. I'm a consultant who can take care of her. I'm acting as ST5. Okay, I'm a consultant in my real life. I'm acting as a ST5 here. But yeah, she'll go out happy because I listen to her. RCUG's guidelines keep saying so many times that listen to the patient, make her feel listened, make her feel believed. So why do they say that? Because the focus is the patient. Patient is the partner in care. Okay, and in the end, you also said actually sentences that I'm sorry, we have to do this. We have to do this. These are not the correct sentences for the patient actually. So not only was your pace, the last sentence was a bit of if they pick up on that one, they will not like that, because it's not, I know you were empathizing and saying that unfortunately we have to do this. You were saying it this way, but what was the problem? There is not, we are offering her. So we are not posing as that we definitely will, as if she doesn't have a choice. Okay. You will say that, yeah, unfortunately the other options are not safe in your case. So this is the safest option. We are saying the same thing, but we are saying in a way, this is the safest option. Unfortunately, we have to do it as a bit of, that you don't have a choice. But we're not saying in that way. We're saying, unfortunately, those are not safe. This is the safest option. Would you want me to, would you like to go ahead with that? Okay. So what you did there was you forced a consent form on me, that there's a consent form, we have to do this. This is called coercion here, that you are coercing. You're not making me a partner in my management. You're saying we have to do this. This is the consent form I have for you. I'll talk to the, so you haven't even asked me whether I should talk to the theater. Are you okay to go ahead? I'll inform my consultant that I've spoken to you. You know, any questions at all that you have regarding this? So you have to satisfy me. Tell me why this is, you know, why is it important? You will say it's safe. So you just need to tweak your sentences towards same sentence. That we have to do is, yeah, absolutely, I agree, we have to, but do we say like that? We don't say like that. We say that this is the safest option. Would you be okay with that? Yeah, shall we go ahead with that then? So you're asking at the same time, do you agree, or you think you can do it? Yeah, there's a lot of time at the moment. Okay, Shilpa, don't look like that. You did, I know, okay, from your previous station, I remember how good you are. Okay, so absolutely, I have full faith in you. Okay, but what I say is that please, I don't know who are the people who guide you this way, that you have to complete. You have to complete with, but with my explanation, the way I've told you, you have to complete. That's a different one. I don't know whether somebody has ever told you that. Okay, but that's the way you have to complete. So please get, this is a very precious time. Don't get misguided. All I can say is that, okay? Yeah. Otherwise, you know all. You know it all. Yeah. Okay. Don't lose heart. There's time. Yeah.
I did that the last time as well. So we have to offer the options. We don't have to put them that it has to be done this way.
Yeah, yeah. You need to, you know, get used to that, get accustomed to that wording. For instance, I'm so much used to that if somebody says it's like a nail hitting me, you know, that why have you used this word? Okay. So if somebody talks in front of me, I don't have to be, you know, having any I don't have any checklist. This is what I have in front of me. Okay. This blank paper on which I'm writing these points. I don't have any checklist. So just remember that you need to tweak your ways in a kind of a way that suits the UK patients. Okay, problem at all.
Yeah, thank you. Thank
Somebody else was also asking some question. I hardly asked about it.
Yeah.
One thing that all those people who have left, they missed is that this patient is in lots of stress because she's thinking, how will I conceive? Okay. So you need to try to accommodate. Another important point here is to offer her mental health support. I said that I'll finally tell rest of the remaining items at the end of our discussion. Okay. So please remember, this is a patient who is in a lot of stress. Okay. So offer her mental health support because she is worried. But let me share with you something that's just to give you a broad idea of what possible bubbles. If somebody is coming to you for recurrent ectopic, okay, with a live fetus in the tube, okay, this is for some other station that I've mentioned medical management twice. That's not, but what I'm trying to show you here is the bubbles that you need quick targeted history, get down to the, so I don't want you to, I don't feel that it's a good use of time to kind of take history first. I'll say just quick targeted 1.2 points and then BBN. Okay, tell her what that is. I can see that your GP referred. Do you know why? Are you aware of the diagnosis? It's an ectopic again. I am sorry. So empathize, pause everywhere. Okay, this station will require lots of pauses. If you start feeling worried that I can't complete this station, then you will lose actually your marks on communication, okay, and patient safety as well. So you definitely must ask. You didn't ask me if I had any children, Salma, okay, and Shilpa asked me about children. So that was a big miss. You should always ask if I have any children at all, okay? Yeah. So that was a huge miss. Was this a planned pregnancy? You didn't ask. You started asking me about my periods. That was a waste of time because there were relevant questions that needed to be asked, and you were asking questions that didn't, that won't do you any good. Okay, asking about blood group or asking about periods, that was a waste of time. Okay, so then you would yes, then you would say that if if I tell you that, I don't have children, then you will ask whether this was planned, okay? And you will empathize more if I say that this was planned, okay? And then you will, if I told you right in the start that this was planned, then that's fine, of course. Then it's okay if you didn't ask, okay? So then about let me see, what do we have? So, okay. So then you will ask her, what does she want to know, okay? So you are asking her, do you want me to talk about management options? If she says yes, then talk about the management options. If she asks you about fertility, talk about that first. Don't try to rush through and don't try to push your agenda. Don't try to force her to listen to your options first because you think you want to complete the station, okay? What is the important history in her case? Previous history of ectopic pregnancy, sexual histories. You ask, you guys should focus on the fact that is she having safe sex? So nobody seems to have asked her about multiple sexual partners as a part. So what are her risks? Her risk was, yes, she smokes 1 to 2 cigarettes. She has a past history of ectopic, but it could be that she has some recurrent STI that was not treated. So you could always ask about multiple sexual partners in a patient who is coming with repeat ectopics, okay? That would be a good idea to ask them, okay? Then, do you get my point? Mufik, are you still here? Yeah?
Yes, yes.
Yeah, okay. So you can stop me if you have any questions. Manikam, you too, and Adila, all of you. Madhu,
Okay, ma'am.
Madhu, you too. If there is any confusion, please ask, okay? But what I'm saying is that...
So for the multiple partners, how will be framing the question? Like how
yeah,
will
that will come with a bit of what we say is, signposting, okay? That can come with a bit of signposting, okay? So that with the risk of, with repeat ectopic pregnancies, there are some risk factors, including, if you don't mind me asking, did you ever had, more than one sexual partners at a time, okay? So you can, because she asked, why me? Why is it happening to me? You can always say gently and very sensitively and with respect that I can try answering your question, Sarah. For that, I just need to ask you a few questions. There could be some of the risk could be higher because of, if she has already told you about smoking, then say it could be higher because of smoking. If she hasn't told, then you can ask that risk could be higher in patients who smoke. Do you smoke at all? So she can say, okay, I smoke 1, 2. So yeah, even 1 to 2, we don't want you to think that they don't harm. Even 1 to 2 can really harm, okay? So that can be one risk factor. Another risk factor is your past history of, an ectopic pregnancy. But there could be other factors as well. Forgive me for asking, but is there any past history of more than one sexual partners at the same time? So because you are answering her concern, you're exploring to answer her questions, and you're respecting, she won't mind and she will tell you, okay? Then what else do you think? Tubal surgery, it would be very good if you asked, okay? Sometimes they could have had some procedure in the past for whatever reason. But people are likely, I kind of find that people are more likely to miss that, okay? So because nobody has mentioned about other tube. I think who was the first one? Ankita asked about surgery, prior surgery.
Should we be asking about the vaginal discharge to correlate with the PID and all the things?
That would be a good idea. Absolutely. Absolutely. Current infection. Okay.
Yeah, because in the HOPI, we can ask about,
yeah.
About
absolutely. So this is your hot area for questioning. Okay. Because if she wants to know. Yes, Alma?
Yeah, actually you told that there is a other tube already removed. You told already before. So that's why I didn't ask you that. The tube.
Okay, yeah.
Thank you.
Of course. So I'm talking about everyone in general. So you don't have to interrupt me for that, because I'm talking about generally for everyone, that what things are missed. Okay. So where would you go next? That You will, if you think that she doesn't have an idea about very safe sex practices, then you will talk about safe sex and gum referral for contact tracing. Okay, so Mofiq, your question was it you or Madhu's question that vaginal discharge? So yes, you will explore that. Okay, and you will let her, you will refer her if required to gum clinic then. Okay, so this
Excuse me
is
to ask, like, can we ask about the contraceptive practice she was using?
Absolutely, because that can be a high risk factor. Yeah.
Yeah.
Absolutely.
Yeah, that is what I was.
Absolutely, you can ask. Okay, so yes, it's a good good question. Okay, so medical, surgical, yes, they asked, most of them asked about smoking, and then yeah, social history. Yeah, nobody asked about any mental health. They didn't explore my mental health, and mental health is a big, if you see, I've made a separate bubble somewhere.
So we have to be asking about how she has been feeling for the past few weeks or months, like, so that will be the woolly questions what we usually ask.
Yeah, ideally you should ask woolly questions, but because this station could go extensive, you can try to shrink it in your way, giving them an idea that you are worried about her mental health. So if you find yourself stuck in a situation where two questions are going to take lots of time, you can still phrase something, say, this must be really stressful, do you want some help? You know, you see what I'm saying? So if you are struggling with your time and you think woolly questions are, you know, a full exercise, you don't have time, even then you can say that this must be so stressful. I really understand. Do you want me to arrange some mental health support for you, some counseling support? We've got very good counselors here, you know? So that will cover, even if you didn't ask then woolly questions, this will cover. Okay, this must be so stressful. Do you want me to arrange some counselors for you, counseling support for you at all? Okay, because, you know, if you remember, I kept saying to everyone that this is so stressful, and none of them said, okay, we'll do that. Yeah,
nobody supported. I think,
if you remember, I said it to everyone deliberately. Yeah, you remember that?
Yeah.
So, and nobody said, okay, I will do something about that. Okay, so so that would be a poor patient communication and poor patient safety, because she may be extremely depressed, and this will be a patient safety issue then. Okay, then yes, if unplanned pregnancy, then if she said it was unplanned, then of course you will explore the contraceptive choices and you'll advise on that. Okay, now what else? Details of the surgical options, you will tell her the details depending on what they've given. So this is for some other stations, so don't worry about that. Most of them, they were trying to attack the management. Fine, I would say fine tune, but yeah. Okay, so extremely high risk of rupture and shock, should mention, which is fine, they did. And okay, and then you'll say that you'll offer her admission. You'll say that my consultant will meet you soon, and then anesthetist will come and have a chat. And then you will also explain the follow-up. If you are doing self-ingotomy, what follow-up is required for that. Okay, self-injectomy, she already had that, so you will say that we will probably not go ahead with removal of your tube, although that will be intraoperative decision by the consultant. Okay, and you will then, whatever follow-up you need to mention quickly, you need to get used to that and see the red circle here. Okay, this was what I was talking about, that you have to offer her mental health support. You remember, mental health support will come in most of your stations. There will be some aspect of mental health support, and if you forget that, that's not good. Okay, how many people offered me leaflets, written information?
Yeah, I offered.
And yeah, I think you did. And I don't remember if the previous ones offered. Yeah, Ankita or Shilpa offered me. Okay, so please remember, it's a good idea to give them written information. Okay, girls, any question, please? Any questions? Are we good?
So doctor, the format of this station will go in the way that the patient has presented to you. So we will start that. I have seen the GP letter and you are here in the clinic with the tummy pain. And so we'll address her pain and give her the pain relief and see her option.
Oh, thanks, Mufik. I have to interrupt you here because you reminded me something good that I wanted to say. Okay. You're welcome, Manika. So Mufik, yeah, about the pain. You remember that I said in the start that I'm okay, I don't have pain. Okay.
Yeah.
But if you offer me pain relief after me saying that, that means
This
your
should be wrong.
attention is poor. You're not attending.
Yeah, listening is not. Yeah.
You're not
Yeah.
attentive. Okay.
Yeah.
So okay. So what I'm saying is that you will always listen to each and everything that the patient is saying, each and every small word. So yes, Mufik, what you was trying to say?
So what we will go through is like we will start the station by saying that I have gathered from the GP letter that you have a lower tummy pain in going by the patient's language, like in the layman language, and your urine pregnancy test is positive and you have undergone a scan and you are here to discuss the scan report. Is it all right?
Would you ask her that did the GP tell you about the scan?
Yeah, so should we inquire that whether she is having any background knowledge, like anything has been informed to her to look for the eyes, like what her is like this one? And then what do you think, that should we go for the HOPI or should we go for the, that is the main problem. Like we have to make our mind.
I feel that breaking bad news give you the option that you dealt with it right in the start and you are ready to answer her questions. Okay. Otherwise, if you don't even know what her questions are and you are hiding this bad news with you and you are asking her history, all your time will become almost dead time because you don't know what she is hiding. Okay. What questions she is hiding. So if I start right in the start, if I give her bad news and then I can deal with her questions, she may have several questions and I can deal with them and I will collect the information as I go and as I require. What do you think?
Okay, so what suppose I give the BBN first, okay, and I don't know what will be the response. So what is your experience like? How the role player usually goes?
Very reasonable response. Okay, what you have to you guys, I don't know who scares you guys. Okay, unfortunately, as I say that, look, there are people who only have the experience of their exam. Okay, so with one exam, even if they score 100% in one exam, it doesn't really matter. They only have experience of just their exam. Okay, and after that they think that they are good to go and claim that whatever I'm saying is right. So when I say things to you based on what we are seeing here, like I'm more than a decade I've been here in UK, and I can tell you that this is how we proceed. Okay, so what happens in the exam, I've even conducted OSCEs for like 4 years as a part of, like at least a bit less than 4 years, okay, as a part of
that's good to know. Yeah, great.
Yeah, sorry?
Yeah, that's great achievement, doctor.
Yes, I've been conducting OSCEs even before, like I was a part of the team, team was only me and my consultant, okay, in London. And it was my consultant's OSCEs. I hadn't done my part 3 at that time, but still I was organizing everything. So I know the ins and outs, not only just from one exam. We can't claim from one exam that, okay, now we can now go and claim to the world that we know everything. That's very unsafe attitude, and more unsafe attitude is from people who just trust anybody for their for their learning. So unfortunately, saying that these people are all doctors but still they can trust just anybody is a bit of concerning, because how do you know? Because that person only has experience of her exam. Okay,
yeah, you're very right. Yeah.
So those people try to scare people that, you break the bad news, she will start crying, your station will be wasted. So some candidates will come out and say this to you, that I said this and she kept crying in all the station. So they are not lying, but the reason is not because somebody breaks the bad news first. The reason is because they didn't handle it properly. Okay, if patient remember a clue from me. This is a big tip. Okay, please remember. If the patient continues to be angry, or if the patient continues to cry, okay, then you are doing some big blunders. Okay, some huge blunders you're doing. Okay,
in the sense like,
sorry,
blunders in the sense like what is
it
the
means
mistake
that
now?
you are absolutely failing to do a good communication, absolutely not getting what she's trying to say. So if that kind of thing happens, that few minutes have gone, then you have to quickly reassess that what was the case. Okay, what did you say to her? What did you do? So you spend 20 seconds here, that what's happening, why is she like this, I'm doing something wrong. She is not told to behave like this. No role player is told to behave like that. They are only told to behave like that if somebody is absolutely off the track. Okay, if somebody misses the point totally, then they do it. So if the patient is doing like that, I even said to my students that, try to come up with sentences like, try to say, uh, I'm sorry, have I missed something? If somebody is angry and if you're not able to first assess in your head for 20 seconds, okay, quickly, what's happening? What have I done? What have I missed? Okay, if you don't think that you're talking and you can have that 20 seconds, you can just say, I do apologize. Can I quickly have a look at your letter again? Basically, you're asking for that 20 seconds gap. Okay, so she will say, okay, and you can spend that time focusing. Okay, what have I missed? What have I missed? Why is she angry? Why does she continue to be angry? You can sometimes do that trick, or if you don't want that, because that is, of course, that shows that you are lost. Okay, but showing that you are lost for a few seconds is not going to fail you if you capture yourself, if you stand up again, and if you are able to handle that 20 seconds lost, saying that let me have a look at your letter again, is not going to fail you. Okay, but if
So
she
in
continues
Osler,
to be angry,
yeah, sorry to interrupt you. So in Osler, the same formatting can be done. Like suppose the patient is crying, suppose the patient is getting angry. So what is the resort? Like what we are supposed to do in that time?
yeah, you can, as I said, first try to think in your head while you are listening to her, and she's talking something, you are thinking in your head, you're trying not to miss what she's saying whilst you are thinking. It's some very much multitasking kind of thing. Okay, because you don't want to miss, it's better that you apologize and you say that Jenny, can you give me a few seconds just to have a look again at the letter from the GP. I don't want to be missing anything. So that why you stopped her from talking. So her anger will, you and then you are pretending that you are looking at the letter, but you can look at the letter as well. Have you missed anything? And in the meantime, you can keep thinking, why is she angry with me? What's the problem? Because when they continue to be angry, there are a few things. One, they want you to come up with all that anti-anger, mm, tips and trips that we teach you. Okay, so that you are bringing her anger down, you are disarming her anger. Okay, they want to see that you have those you have those tricks and those competencies to address the anger. In the meantime, if they still are not getting simmered down with all your efforts, then it means you've missed something really big. Okay, or you have said something really foolish there. Okay, so then you have to address it again. The best thing would be to straight away try to think, and if you're not able to think, I said there is no harm in then saying that, Jenny, I'm afraid, have I missed anything? Am I on the wrong track? Did you want to talk about something else? Something like that. If she's saying you're not listening to me, I do apologize. Did you want me to talk about something else? So, ask her, explore with her. They want to see this good communication in you, because this thing can happen in the clinics, in our clinics. And it's on us to simmer down their anger, try to understand why. People are not mad. They don't come to the hospital just to be mad, just to be angry. Okay? So it's our job to explore, why is this person behaving like that? So if this happens in the exam, definitely make sure that you haven't missed out on anything. So what I will do, I will first quickly rethink what's happening. What have I said to her? I will quickly look at the letter and see, oh, have I missed anything? Have I missed? Okay, no. Then if not, then I'll ask her and say, I do apologize, Jenny. I know you've been through a lot, and I know it's very stressful, and I'm honestly trying to help you. I'll do my best to help you. Is there anything that you think I've missed in your history? Is there anything you think I'm not focusing on? And she can then say, Doctor, I wanted this to be. So sometimes saying things like that, you may not have missed something, but you said this and she likes this now, because you are coming, kind of down on your knees, that can I, I'm here only to help you. Okay.
Yes.
Yeah?
Yes. Thank you.
So you don't have to worry about breaking the bad news first. Should not be a scare for you, that what will happen, she will become angry or she'll start crying. I think that's a very good tactic, that you deal with it, because then she will have questions and you can answer her questions. Okay.
So the formulating the sentences before breaking the bad news, does it vary from station to station? Like if you are
Absolutely. There would be hundreds of ways. Look, what do you do in your language, like in Urdu, Hindi, Arabic? What do you do? You don't. It's not just one sentence that you use. It depends on the situation, what the situation is, and according to that, you will go and you will talk that way. So there can't be one sentence for everything. Yeah.
Yeah, you are very right. And the presence of mind is very important, I think, like in a 10-minute time frame, if you have to.
Presence of mind, and absolutely attentiveness in terms of, and the flow of language as well. Okay. You need to know what your words, how do they impact? Okay. Heard a little bit and they went quiet.
No, I was asking about the different sentences we have to formulate, like according to the stations, like. So that will be very.
How would you do that in your own language? Just like that, yeah? It would be different sentences. Okay.
Okay.
You need to imagine various scenarios and imagine the sentences then. That what are you going to say in different scenarios? Okay. So with every station, there are different scenarios. Like with every station, we keep on, when I'm teaching my students, we keep on coming with, it's like sometimes almost dictating sentences, like say this for this situation. No, don't say this for this situation. Say this for this situation. So it's a very in-depth preparation. Okay. And all of you need to go through the station and see what sentences for what situations. Okay. So it's not something that you can do in one sitting. It's something very extensive, and this is what we do focus in our, when we are doing various stations with our students. So this is what we focus. Okay.
Okay. Thank you.
Okay, girls, anything else? Hello, girls. I am fasting, but it seems like you're fasting. I've been talking throughout. Hello, girls. Okay, no more questions then? Yeah?
Ma'am, you look lean.
I look lean?
Yes, ma'am.
Maybe I have, honestly, is it Manikam? Yeah?
Yes, ma'am.
I can recognize your voice, Manikam. Okay. Yeah, so I only lost like half a kilo of weight, don't worry. I think it might have gone from here. So with fasting and all that, my husband and myself, we always keep jumping on the scales to see who has lost more. And we laugh that I've only lost like half a kilo. Some days it looks like a kilo, but yeah, not much luck with that. Okay. Thank you. But thanks for saying that, because it feels better, reassuring.
Yes, ma'am.
Okay, girls.
But you don't look that you are fasting.
Yes.
I don't.
You are eating something. You look
no, that is a spiritual power she has gained through fasting. Spiritual power you have gained. Man,
spiritual power.
Power you have
Okay,
gained
not
through fasting.
malnourished. Yeah. Okay. Okay, that's good. That's good to have spiritual power.
Please pray for us, Sam.
No, I am praying for all of you, inshallah.
Yeah,
Okay.
thank you.
You all very very good luck for your preparation. Okay, so
Yeah.
Purnima, we haven't met. I think Purnima. How are you, Purnima?
Yeah, ma'am, I'm fine.
Okay, when are you appearing?
November.
You're for November. Okay, okay,
Yeah,
good,
yeah.
good luck. So good luck, girls, and good luck, everyone. So it was lovely having all of you here. Okay, Madhu, you didn't speak a lot. I don't think you spoke at all. Bye, Mufik, and all of you guys, unless you have got any other question, any burning question, I'll finish the meeting. Okay.
Thank you very much.
Bye,
We
girls.
learn and we
Bye.
get relaxation
Bye.
also. Love some.
Bye.
Thank you.
You too. Allah Hafiz. Allah Hafiz. You take care.
Bye.
Okay.
Yes. I'll start. Hello, I'm Dr. Salma, one of the doctor in the clinic today. May I check your name, please?
Hi, doctor. I'm Sarah Taylor. I'm 23.
What would you like me to call you?
Sarah is fine, doctor.
How are you, Sarah?
I'm okay, doctor.
Sarah, I can see you are in pain. Do you want me to give some pain relief, or you are comfortable to continue the conversation?
No, doctor, I said I'm okay.
Okay. I have received your GP letter. It says that you are in pain in your lower tummy, and you also want to know your scan report. Am I right?
That's right, doctor.
Yeah. So do you want me to explain the scan report first, or can I ask you some relevant question? What do you think?
I'd like to know my report, doctor.
Okay. So Sarah, as there is some concern, so do you want me to call somebody, or you have someone then I can call?
You can talk to me, doctor. That's fine.
Right. Sarah, actually, I don't have good news for you.
Okay.
Yeah, your scan report says that you had a pregnancy outside the womb.
Again. Oh.
Yeah, the
Okay.
pregnancy.
Oh. Oh, okay.
I'm sorry to give you this information. Do you want me to continue the conversation?
Yes, please. Yes, doctor.
Yeah. So, Sarah, can you tell me more about your condition, please?
What do you want to ask, doctor?
So, how is your pain, and when it is started? Can you tell me more details about that?
I'm just having pain for 2 days, doctor.
Mm-hmm. Do you have any other problem, like any waterworks problem or upper tummy pain, anything?
No, doctor.
Mm-hmm. And what about your period? When your last
Periods
period?
are fine, doctor.
Mm-hmm. And do you smoke?
Yes, I do.
Mm-hmm. As you said that it came again, that means you had before, what I understand?
Yes, doctor. 2 years ago, I had pregnancy in my right tube. They removed the right tube.
Mm-hmm. Can you tell me more about that? How is the recovery?
It was okay, doctor. I went home after 2 days, so it was okay.
Mm-hmm. So can you tell me that what is your height and weight ratio?
It's 22, doctor.
Mm-hmm. Do you need a blood group?
No.
Thank you for sharing all information. Do you want to add anything?
You can ask anything, doctor. I don't know.
Mm-hmm. So, Sarah, do you have any concern or any expectation that you want to share?
Just doctor, I don't know why this is happening and what to do. And we were planning this pregnancy. I don't know what we'll do about that. So I don't know.
Sarah, actually, you know that it can happen if you have before also. You told me that there is a pregnancy outside the womb and you smoke also. Yeah, it could be another risk factor. And I would like to ask you, do you have any sexually transmitted infection before? Sorry to ask you this personal question.
I had when I was 16. It was treated, doctor.
Right, good. So this could be another reason also. It makes the scarring more in the tummy. So there is a risk of pregnancy could be outside the womb. Am I clear, Sarah?
Okay.
Yeah. So Sarah, do you want me to explain the management plan?
So does it mean I'll always have this? If I had infection in the past, will I never have a baby?
No, you can get baby, but there is a risk that it could be recur. Okay, 7 to 10 out of 100 women, there could be recurrence rate. Am I clear, Sarah?
Okay.
Yes. So, do you want me to explain the management plan?
Yes, doctor. And how will I mean, I also want to know how will I have any babies?
Yeah. So actually, you can get pregnant, but it depends our management plan. Okay. I'll explain you in a minute. Okay. So first of all, we'll advise you for admission. Okay. And we'll do. You will be seen by specialist team. That means our consultant. Yeah. And then also that that anesthetist, specialist nurse. Yeah. All will be in your care. We'll do some test also for you if you agree for admission. Yeah. And then there is a different option that the medical management, surgical management, but this medical management is not suitable for you. Yeah. But what do you think? Do you have any preference?
I don't know I don't remember what was the medical.
Yeah, medical management, that means there is an anti-cancer medication. Okay, we'll inject your muscle. Okay.
Can I have that?
Actually, this is not suitable option for you.
Oh,
because the baby. Sorry, yeah.
No, it's okay. You can tell.
Yeah, because there is a heartbeat in that pregnancy. There is a baby heartbeat. This is a one risk, and also that you have pain. So this medical option is not suitable for you, I'm afraid, Sarah.
Okay.
Yeah, so that's surgical management. Okay, so surgical management, there is a one option that to remove only the pregnancy, and there is another option to remove your tube totally. Okay, so to remove the pregnancy only, there is a risk that 1 in 5% there could be, that interfere with the anti-cancer medication or need further surgery. Okay. But this to remove your tube only. Okay, so that's why there is a risk of recurrence also less, and also that it will be better option for you. So what do you think, Sarah?
That's fine, doctor. If it's the only choice, then yeah.
And as you have before also tube remove, and now also if you remove this another tube, okay, then there is an option also that test tube baby, to try with the test tube baby. So in that case, we have to refer you, we'll offer you to, that to refer the fertility clinic. They will explain you more about that.
Okay.
Yeah.
Okay.
So what do you think, Sarah?
I don't know, doctor. I'll need to speak to my partner.
Yeah. No worries, you can think yourself, okay, and I'll give you the written information. You can take your time, but there is also that it is as it is in the tube, it can burst anytime.
Can I go home?
yeah, if you go home, if there is increased pain or anything, you may come any emergency situation, because this pregnancy can burst in the tube. There is a little space, the pregnancy cannot grow.
Okay.
So at the time in emergency situation, we have to do the operation, and it is life-threatening also, Sarah.
Okay.
Am I clear?
Okay.
Yeah.
So stressful, doctor. So I don't know what will happen now. I don't know.
Yeah, so I'll give you written information. You can think about that, okay? And take your time, and I'll come back. Yeah. And you can, by this time, nurse will come to ask you. Yeah. So let us know. What do you think?
Nurse will come, doctor. You said I can go home.
No, you want to go home? What do you think?
You said I can go home.
No, I'm telling you that there is a risk that, it is life-threatening condition. If you go home, anytime you can come with severe pain, and we need emergency operation to remove your pregnancy.
Okay.
Yeah.
Okay.
Thank you.
Okay. Okay. How did you think it was?
I tried to satisfy you, but I don't know.
Okay. Anyone else? Any feedback? Okay.
That what I have done, that to ask that what you like, that I'll explain your report first, or I'll ask some history. So you give me permission that no, you can tell me the scan report first. So I go that way. Yeah. So do you think that we can do like that? That if you'll allow me, then I can go that way. Otherwise, if you tell that no, you can take history, no problem, then I'll take history. What do you think?
Yes, yeah, that should be fine. No